Hello, everybody. I hope you are seeing my screen. Not easy to give an idea of what's going on in Italy regarding ischemic stroke and thrombectomies in few minutes. So I will just try to highlight some issues and some positive aspects, and also some future scenarios regarding this pathology. Let me see if I can go forward. Yes, I don't have a disclosure regarding this presentation. Just to say a few words about our roots. We started doing the first cases in the 90s, and this is probably 1998, but might be some years before. A young lady, 49 years old, that came in with a left hemiparesis, and we brought her to the angio suite and find out a occlusion of this M2 segment. This is by far earlier than all the ischemic stroke scenarios that now we have in front of us any day. It was really another century. So what did we do? We went up with a microcatheter, did a run, having passed the occluded segment of the artery, and then we recanalized just by injection of fibrinolytic and some mechanical disruption. And that was the post-op, post-procedure CT, and then the control at 4 days. So we started doing some little by little with no evidence of anything, but at that time, in the 90s, not even the IV thrombolysis was on board, was available. So this is really the Jurassic of this pathology. This is another case, 55 years old, female coming in with an M1 occlusion, MCA occlusion. It's the distal segment of M1 before the trifurcation. Again, we go up with a microcatheter, do a run, and then we inject 600,000 units of urokinase, and we disrupt the thrombus with the microguide wire. At that time, there was no synchro, no Traxxas, no hybrid, nothing of what we have now. And also the microcatheter was less performant, much less performant. But this is to say that this was the beginning, and we were enthusiastic about this. We were able to recanalize, and if the patient came in time, we had very good results. So this is just to start. Where are we today? We recanalize more or less 80 to 90% of the arteries, thanks to our skill that we gained over the last years, thanks more or especially to the new devices and the new microcatheter, the new aspiration catheter. So we have a high degree of recanalization, but still 50% of good clinical results. So based on this is a partial occlusion of the tip of the basilar. Based on this, we don't have great technical issues. And for the moment, at least in some areas of Italy, we don't even have economic issues. So we have money to invest on that. So these are not the problems. This is an aspiration catheter, and in 20 minutes, we recanalize the tip of the basilar. So the issues are more elsewhere. I would say mostly linked with the organization. We are 60 millions. We have 20 regions or counties or whatever you want to call it. But this means that we have somehow 20 different healthcare systems. We have, as everywhere, national rules, but we have a lot of regional governments rules. And in addition, we have a huge gap between north and south. So, as you may know, north of Italy is richer. It's not because of me, but that's the real word. And the south of Italy is poorer and have less availability of means, of equipments, of transportation, and so forth. In Italy, as in many other Western countries, stroke is the first cause of disability and the third for death. We have 185,000 cases per year. So now we focus a little bit more on my region, which is Lombardy. We have 10 million people, 20,000 cases per year, and around 15 hubs for thrombectomies, meaning hospital second level that can deliver thrombectomy procedures. This is Lombardy. These are the hubs. We have on the south we have the lowlands, so that the ground is flat. We can transport quite quickly, and in the north we have the mountains, and this is a problem in this region. Especially, we are organizing the Winter Olympic Games next year, so we have money to invest on transportation and on hospitals, but the same. The problem is probably everywhere you have mountains, so the distances not huge, but the time is long to get from one hospital to the other. And it's not easy to cope with this problem. This is Milano, the great Milano. We have 4 hubs and a 5th hub just on the south of town, and another hub just north. So probably compared to the population, which is more or less of, let's say, 2 million people, probably it's over-covered. And as in many other places, the real issues are in the big cities, not in the small towns where the hub and spoke organization is much more clear. So we started in 2015 with a hub and spoke organization. We had, as I said, 15 hubs for thrombectomy and around 35 spokes to deliver IV thrombolysis. Main issue, as probably in other places, is the secondary transport from spokes to hub, which takes at least 2 hours. Whether it's 2 kilometers or 20 or 30 kilometers, it doesn't change a lot. So the problem is to have the ambulances, to have the medical, the physicians or the anesthesiologists to go with the patient and so forth. Nothing new. Interestingly, from 2024, the Lombardy government decided to switch to a mothership approach, meaning to direct transport to hubs the patient with the strokes, just to bypass, to overcome the long time of the secondary transportation. In fact, as you may know, there is no proof that this model is more effective or that you gain something. And you might have pros and cons of this approach. And what we are experiencing, it's curious and interesting for some aspects. Obviously, the advantage should be, the idea behind is a potential faster arrive of the patient to the hub, and so a faster, let's say, door to needle or home to needle thrombectomies. On the other side, you might have a potential delay in IV administration because some patient that might benefit of a IV thrombolysis in a very near hospital will be taken to a hub which is a little bit more far away. And generally speaking, thrombectomies accounts for 60 to 80% of all strokes. So we are moving a lot of people to have a small gain, even if for the patient with a large vessel occlusion, that's a real gain. The problem of strokes, which is exactly the opposite of MI, of the cardiac patients, is that we don't have an EKG analog, so we have no reliable pre-admission scale. So basically 50% of the patients that are taken over to the hubs do not have a stroke. So consequently, you have an overload of the hubs, of the emergency rooms, and it's very difficult to, let's say, get rid of the non-stroke patient or of the patient that just have an IV administration thrombolysis, and then you have to take them elsewhere because your hub is overloaded. So again, there are pros and cons, and we are now in Lombardy dealing with this problem. What are we still missing? A centralized imaging network, which would help a lot. Still, we have any hospital managing, buying, and dealing with its own PACS system, which is not centralized, not even for the region, but not even for the areas. So hub and spokes have difficulties in sharing images, so that very often we go by WhatsApp, which is a good system anyway, even if we can say that. The automatic software is not everywhere available. So in Lombardy, there was a regional law that obliged all the hubs to take this, to buy this IA system, and we are on the way. But as many things in this country, it takes time. And we lack physicians. And this is probably not only in Italy, but it's a problem. And it's a huger problem the more hubs you have. So you have a small staff made, let's say, of 3 people. If one gets sick, if one moves away, then you're in big trouble. And you should close that hub and bring the people to other places. So this is a real problem now, which will be probably solved in some years, not less than that. What about the future? This is to show that more and more we are dealing not with thrombectomies, but with symptomatic cerebral vessel strokes due to stenosis. More and more, this is a case, tight stenosis of the basilar. We go for that, PTA, and then stenting. Why do I say this? Because probably rescue stenting might bring an additional risk, especially for those patients who had IV thrombolysis on board already. So we started a study called STARS, which is an Italian study, observational multicentric prospective, with 2 arms, acute stenting after IV thrombolysis and acute stenting with no IV thrombolysis. We just started, we recruited 100 patients so far, but the target is at least 400 patients. But this is something that we are encountering more and more frequently, more and more often. Another scenario, as you know, is the MEVO issues. We obviously read this paper by Marius, and we went back looking at our MEVO's cases, and in fact, in the last 15 MEVO occlusion, we had no complication and clinical improvement in all cases. So obviously, few cases, and this paper is much more statistically significant and valuable and reliable, but we have doubts, and probably there will be discussion about these MEVO problems. This is one of the possible scenarios, the one-stop management. I will not go deep into this subject, but it's something that we will see more and more in the future. Again, one possible future scenario, the rescue bypass, which I love. Will it be really a solution for the failed thrombectomies? We don't know, but hopefully we will have more and more the neurosurgeons on our side for this kind of treatment. One possible scenario will be that drip and drive, at least for a temporary solution for not having so many interventional neuro guys, and in the long future, teleproctoring and teleprocedure might be another nice scenarios. And that's all, and I thank you very much for your